So let me start by changing my title to mother-to-child transmission, and I will explain that to you later. And then pediatric HIV. Okay, so we all know that maternal-to-child transmission of HIV is during the pregnancy, labor, and delivery, and breastfeeding. So that's included. So it's also referred as your vertical transmission or perinatal transmission. And majority or most of these very young infants and neonates are infected with HIV through maternal to child transmission. So prevention of or the PMTCT is a common term for programs that was presented earlier, yung having the 4 prongs, no? But I will discuss further on the prong on the child, no? Or the infant prophylaxis. But now, it actually, the WHO is now going into elimination, hindi na prevention. So I hope that the Philippines will soon be part of the elimination of mother-to-child transmission, which is now has 15 countries. No? Ang pinakamalapit sa atin is Thailand and Malaysia, having Thailand having eliminated the maternal-to-child transmission. So it can be done. So WHO recommends the lifelong ART for all people living with HIV. Okay, and that includes pregnant and breastfeeding women. But in countries like where women are infected with HIV, their MTCT is through giving them long-term combination or the lifelong ART. But there are actually some discussions on probably giving only the ARTs during pregnancy, mga ganon. Because we have so many new drugs and they are effective drugs. Okay, and then in industrialized countries, they do not breastfeed. Nakita ko yung poll earlier, but I can explain later, no, some of the local policies by the DOH and why we included that in the policy. And then they also have elective cesarean sections, which are really safe and feasible, and then are commonly performed. So the rate actually has been reduced and even eliminated. So in the Philippines, what is our country data? So I look into the 2021 data that shows us, no? Remember, the percentage should increase, okay? So as you can see here now, the 2010, so this is 10 years, no? The percentage of women living with HIV who has access to antiretroviral drugs is still very low, at 26%. And this may have been affected also by the pandemic. And so the final vertical transmission rate, including during the breastfeeding, is about 35%. So early infant diagnosis is just about 6.3%. What we're seeing here is that we are very, very far from the goal, no, of elimination. Okay. So I have some questions, no, just to review lang, no, every time I show to you the facts, no. So mother-to-child transmission is the transmission of HIV from an infected mother to her baby at what stages? So based on the slides, sana nga may ano ko dito, but whatever is your answer, no, this is just as a review. So again, it's during pregnancy, during labor, delivery, up to breastfeeding. So it's all of the above. Now, looking at the children living with HIV, this is a global data, not receiving treatment by age group. No? Ang laki-laki pa rin po, ang taas-taas pa rin. So the 0 to 4 years, about 37%. 5 to 9 years is 23%, but the 10 to 14 years, higher pa, 40%. Almost 2/3 of children living with HIV are not on treatment. No? So the gaps in the possible things are the gaps in testing of infants and children exposed to HIV have left more than 2/5 of children living with HIV undiagnosed. Remember, these children will not go to the clinic alone. No, they have to be brought by their caregivers. So the thing is, we pediatricians would always depend on the caregiver, the parents. Okay? And most of the time, even before the era of the ARTs, diba, these parents die also from HIV. So they are being left to the grandparents or even caretaker or left for adoption. So there are so many factors that would really affect the diagnosis, okay, and even treatment of children with HIV. And the number of children on treatment globally has declined, okay, leaving almost 800,000 children 0 to 14 years of age not on the antiretroviral therapy in 2020. So what do we expect during the pandemic, which is 2021 and going to 2022? Okay. So a comprehensive approach in reducing HIV infection in mothers, infants, and even the young children is a comprehensive package of care. And this includes the following. Let's start with the maternal testing, treatment, and monitoring, because we all know that majority of these infants and young children get their HIV through maternal to child transmission. Okay, so very important yung maternal testing, treatment, and then monitoring. Next would be the infant diagnosis. So once the child has been born, we have they have to have an access to the program, which would timely identify these infants and start the prophylaxis, and then and this does not end when they are born, because it has to be continued up to. That's why the postnatal care is very important. So the monitoring of the infant born to an HIV infected mother continues up until you have identified that the infant doesn't have the HIV. Okay? So that includes the postnatal prophylaxis, and then also the cotrimoxazole prophylaxis to prevent the opportunistic infections, and it also has been found to decrease mortality of infants and children living with HIV. And then and the last would be nurturing care that would actually have to provide interventions to promote childhood development, and also support for not only for the child but also for the family. So what are the components of this comprehensive approach? So my question is, the components are the following except. So the exception is rifampicin prophylaxis. It should be cotrimoxazole prophylaxis. So the latest data have shown that infants acquiring HIV vertically is caused by the following findings. The greatest actually is this one. The number one is the mother acquired the HIV during pregnancy or breastfeeding. The mother did not receive antiretroviral therapy during pregnancy or breastfeeding. And the mother did not continue with treatment during pregnancy or breastfeeding. And the mother was on antiretroviral therapy but not virally suppressed. That's why one of the recommendations for pregnant women is to do viral load testing at least a month before the expected date of delivery, so we will be able to see, even if she's on antiretroviral therapy, so that we'll be able to see the viral load, and you will see later that it will affect the management for the infant. So that the infant prophylaxis, okay, or the management for infants born to HIV infected mothers, one good practice, okay, is to initiate your ARTs urgently among all pregnant and breastfeeding women living with HIV, even if they are identified late in pregnancy or postpartum, because it is the most effective way to prevent transmission, to reduce the maternal viral load. Okay, and defining the high-risk infants or low-risk infants is now the consideration when we assess the risk of the infant. Okay, so they have seen now that the factors such as prolonged rupture of membranes, preterm delivery, or low birth weight are no longer associated with increased risk of transmission when the mothers are receiving ARTs. Pagka hindi ko talaga uminom ng, or the HIV infected mother is not taking ARTs, so lahat talaga yon, high risk agad ang bata. But if the mother is receiving ART, malilesen na yung aming risk for the babies to acquire the infection. So the critical determinants now for the transmission risk in this era where we have very good ARTs available, are the maternal viral load and the duration of maternal ARTs. Okay, so that's I hope that have answered the question earlier, that why do we need to do the maternal viral load at least a month before delivery. Okay, so the maternal or infant factors that are no longer associated with increased risk of transmission of HIV to their infants when the mothers are receiving ARTs are the following. So except, so the factors, prolonged rupture of membranes, preterm delivery, low birth weight, and high maternal viral load are still the ABC are no longer associated with increased risk. So the exception here is the high maternal viral load. Now, after defining the risk for the infant, okay, or the newborn, so it is determined by the risk of possible perinatal transmission. Okay, so we have definitions for the ARV regimens that will be given to the baby. So the ARV, when we call ARV prophylaxis, this is for the HIV-exposed infant. Okay, the prophylaxis is the administration of one or more ARV drugs to a newborn without documented HIV infection, because we want to reduce the risk of perinatal acquisition of the HIV. So that is what we call the infant prophylaxis. When we have presumptive HIV therapy, no, this is the administration of the 3 drugs. So automatic, the minimum number of drugs given are 3 drugs to the newborns who are at highest risk of perinatal acquisition. So it is actually intended to preliminary do treatment na. So parang prophylaxis is equal to treatment. For a child who is at higher risk for the transmission or the acquisition, because that can be determined later. No? Baka pag mag-positive na siya. So pag nag-positive siya, then we just continue the giving of the ARVs. Okay? And those, and when we say HIV therapy, this is the administration of the 3-drug regimen at treatment doses. Okay? So, when you say a newborn's ARV regimen should be based on maternal and infant factors that influence the risk of perinatal transmission, and you start prophylaxis. So prophylaxis is best defined as, okay, so it's A, the administration of 1 or more ARV drugs to a newborn without documented HIV infection, because we want to reduce the risk of perinatal acquisition of the HIV. Okay. So this is now the algorithm of risk assessment to better understand how we classify or identify these infants at high risk or low risk of infection. So we assess the mother at delivery. So if the mother is with known HIV infection, but not on ART, then the child or the infant is identified as high risk. Okay. Then if the mother is a known HIV, but on ART, thus we look at the viral load result. At least 4 weeks before, less than 4 weeks before the delivery. Because depending on the viral load, again, as a pediatrician, number 1, if the viral load is more than 1,000, we all know that the transmission is highly possible. That's why we put the child as, identify the infant as high risk. But if the viral load is less than 1,000, then we identify the infant as low risk. Now, if there's no viral load determination, but the mother has been on ART for more than 4 weeks prior to the delivery, then we can identify that infant or assess that infant as a low risk. But if the mother has just started ARTs less than 4 weeks, then we still have to put that child's assessment as high risk. So definitely all mothers newly identified as HIV positive within 72 hours of delivery will be, the infant will be high risk. So the recommendations for ARV prophylaxis depends on the risk factors based on what I have discussed earlier. Okay, and these are the recommendations. And I will discuss that more intensively later. I just want to show you that the list of our local antiretroviral drugs available. This is 2018. We have actually updated this because in the adults, in the adults, we have new drugs coming in. Okay, new combination drugs coming in, and in the children, I will show it to you the differences in their availability. And this one, the infant ARV prophylaxis that we give to or that we follow, no, we will actually modify this. We have actually decided on the newer version of our PMTCT and the treatment administrative orders by the DOH, but it hasn't yet been signed due to the pandemics. So I will be explaining to you, no, now the latest recommendations that we will put in the newer AO, and we hope that this will be signed and then and disseminated so that you will now have the what's that updated AOs. So based on the risk assessment, okay, so low risk of perinatal HIV transmission. That means those mothers who are receiving ARTs with viral suppression, and ARTs have been started more than 4 weeks prior to delivery, and no concerns related to the adherence. Thus, our infant prophylaxis is now just one drug, Cydovidin or nevirapine for 4 weeks. For high risk of perinatal HIV transmissions, no, again, the 4 risks that we have identified, then we do presumptive, or we give presumptive HIV therapy using either 3 drugs, 3 treatments, 2 or 3 drugs, up to 6 weeks, and can be extended up to 12 weeks. But if the newborn is presumed to have a HIV infection, for example, the mother was just tested right after delivery, or the mothers have unconfirmed HIV status, okay, tapos nag-deliver na siya, and then was just identified to have the positive test. So we have to give the presumptive HIV, or the HIV management or therapy. So this is just a simplified age-based antiretroviral drug dosing. So for those who are giving nevirapine or Cydovidin, or if you want combination 2 drugs, okay. But it has been shown that 1 or 2 drugs are also the same, have also the same outcome as those giving 3 drugs. That's why for low risk, we just want to decrease the number of drugs for prophylaxis to 1 drug. Okay. So you have to remember this, that the risk assessment for the infants for possible vertical transmission will have to be those with mothers, women with established HIV who have received less than 4 weeks of ART at the time of delivery, or lang ho ito, so you don't have to satisfy all the 4, but any of the 4. So those women with HIV and a viral load of more than 1,000 copies, at least 4 weeks before delivery, or if the woman acquired HIV during the pregnancy or during breastfeeding, or women who have been identified for the first time during the postpartum period, or with or without a negative HIV test prenatally. So presume that it is positive, HIV positive. So how do you now diagnose an infant no, exposed to HIV? Mas matrabaho yung infant eh, no, exposed. So we have to have the virologic assay, which is the RNA or HIV DNA nucleic acid tests, which is now readily available, which directly detect the HIV. And it has to be used to diagnose infants less than 18 months of age, okay, with perinatal and postnatal HIV exposure. Why? Because the maternal antibodies can be transmitted to the child. And these maternal antibodies will just be consumed by the time of about 12 months to 18 months. That's why if we do HIV antibody test or the antigen antibody test, it might just detect the antibodies of the mother and not purely the infant. So virologic test is is the one that is specific for the presence of the RNA or DNA in the blood of the child or the infant. So we follow this algorithm. So, but again, this is coming from WHO. So the recommendation is to do virologic testing or considering nucleic acid test for babies exposed to HIV positive mothers 0 to 2 days, and then repeat it 4 to 6 weeks. But actually there are choices. In our setting where the NAT or test is not readily available, okay, or if it is available, it is expensive. So it's more cost effective that we do testing 4 to 6 weeks. Since we are also giving the prophylaxis at least within 6 hours of life or after birth. So we start prophylaxis. And then our local recommendation is do testing of the child 4 to 6 weeks of age. Okay. So once anything that has a positive HIV or not test, nucleic acid test positive, we already identify that child as infected and immediately start ARTs. Okay, but we also do or parallel confirmatory tests or repeat it again, in 1 to 2 weeks if you are really not if you really want to be convinced that that child is positive. But even one test positive, we already identify that child as infected, okay, and immediately start ART treatment, not as prophylaxis anymore. Okay. Now, if the initial test at 4 to 6 weeks of age is negative, the HIV infection is not detected. But if the infant or the child is being breastfed, so there is still a risk of acquiring HIV infection. Thus, we do regular monitoring, then repeat the test at 9 months. And if it is negative, the HIV is unlikely unless the child is still breastfeeding, because the expectation is that probably at 6 months of age, they will cease their breastfeeding. But if the child is still breastfeeding, so we have to repeat the test again at least 3 months after cessation of breastfeeding. So if that will be more than 18 months of age of the child, okay, So yeah, whichever is later. So if the child is now more than 18 months, so antibody testing can now be done on the child instead of doing the NAT. Now, if there's an initial negative and during regular monitoring, you repeat the NAT at 9 months of age, okay, so then there's a positive test, then we immediately start treatment for ARTs. And again, repeat the NAT to confirm the infection. Okay. So diagnosing an infant, again, do virologic diagnostic test at least 14 to 21 days, or actually, technically, it has to be at least two tests being done. So at 1 to 2 months, and then repeat at 4 to 6 months. For those infants, although these are just recommendations, for those infants who are at risk of perinatal HIV infection, so WHO, this recommend virologic testing at birth and at 2 weeks or 2 to 6 weeks. Then any positive virologic test should be confirmed as soon as possible by a repeat virologic test. And then if positive, but you don't have to wait for the repeat or confirmatory test to start your ARTs. Once you have a positive result, we start ARTs. So definitive exclusion of HIV infection in non-breastfed infants is based on 2 or more negative virologic tests. And with one test, negative test obtained at least more than 1 month of age, and then another test more than 4 months, or 2 negative HIV antibody tests from separate specimens that were obtained at the age of more than 6 months. Okay, this is a special case. They would allow antibody testing for children less than 18 months of age if you do not have the NAT test or the NAT test or the virologic test. Okay, now the issue on postnatal transmission, that is through breastfeeding. So the dynamics now have shifted towards the transmission during the postnatal period, because we have seen that if the mother has been started on ARTs, it's really very effective to the prevention of the transmission. And then now we see that after delivery, sometimes they don't continue the ARTs. So, and they do breastfeeding. Okay. So again, postnatal transmission through breastfeeding is still a problem, or source of infection for infants. So final diagnosis should be conducted at least 3 months after breastfeeding. So for those breastfeeding mothers, and the baby should be tested 3 months after cessation of your breastfeeding. Okay. Now, regarding transmission of HIV while breastfeeding, so remember that for people living with HIV, when you have undetectable viral load in the blood, is actually now equal to no risk of transmitting that the virus to your partners. And so the question now is the undetectable in the breastfeeding mother also equal to no transmission to the baby? So research on breastfeeding women with HIV that includes the viral load data is very limited. Okay, so the evidence that still exists now is that the undetectable viral load provides significant protection from HIV transmission. However, there are still cases of HIV transmission among breastfeeding women with undetectable viral loads. So currently, so again, yung poll natin kanina, no, sabi nyo nga, are you gonna, ano yun, counsel for breastfeeding or not, or milk formula. So if you will look into the different countries that have eliminated the transmission of maternal to child, transmission of HIV, most of these countries are high-income countries where they recommend women living with HIV not to breastfeed, okay, even when they are virally suppressed, okay, because they have available milk formulas, clean boiled water are accessible. So the risk for having a dirty water or malnutrition has been eliminated. So yung support is very high. But in low and middle income countries, the risk is far greater. So which means the babies, there are babies, if the mothers would stop breastfeeding and they don't have any other alternative milk formulas to give to the child, so the risk for diarrhea, malnutrition is very high. So those are the countries that would recommend exclusive breastfeeding, okay, at least up to 6 months of age. Okay, so this is just a graph that would show you how to approach a child for the package of care, where you will do routine testing, okay, if the infant is low risk or high risk. Okay, you can extend prophylaxis up to 12 weeks or stop it at 6 weeks if the infant is not breastfeeding, like that. Okay. So, elimination of vertical transmission, it requires improvements across a continuum. So the program needs to become better, and it has to empower not just the women, but also the whole family and even the caretaker of the child. So the most recent data have shown that children are being left behind. So this just shows us that in 2020, in adults or those 15 years old and above, compared to children 0 to 14 years of age, there's just about 40% of these children with HIV would have suppressed viral load. So mas mababat ang children than in the adults. Again, that's why the comprehensive testing approach for infants and children is being suggested. So infant diagnosis, I have discussed about that. Then you also have to do targeted testing. Those who are HIV exposed infants and children whenever they present sick, or to offer to determine the exposure status of these infants and children who present to outpatient and immunization clinics. In our setting, in a hospital setting, you can actually do facility-based testing. So those patients who present or children, infants and children presenting with severe TB, disseminated TB, those who are also malnourished, okay, inpatient wards or inpatients who are presenting with clinical manifestations, or symptoms of HIV, probable symptoms, okay, and also this one is added, you test the infants and children living in the households of known HIV parents or siblings. That this always happens to us because sometimes they would be able to identify their HIV after 1 to 2 child na, no? So we have to test everyone after we have identified an index case in the family. Okay, so again, the symptoms for HIV in children now are almost the same as in the adults. We look into the possible transmissions. In children, so first in infant age, usually maternal yon, maternal to child transfer. When they grow up, the older children, depending, we have to identify if they had the sexual intercourse early. Alam niyo naman ngayon, as early as 9 years of age, meron ng nagsisexual intercourse in children, or sexual abuse, in the family. So actually, those are the entry points where we get these children with HIV because of the possible other transmissions of HIV. Okay, so also it's a mother to child, but also the contamination. So the thing we see in adolescent age, so that is above 15, because this 15 to 19 years old are still pediatric patients. So we get those with HIV contaminated needle, okay, or alam niyo yung casual sex, okay. Madaming history yan. So the staging, clinical stage, that of HIV may differ from adults, Pag adolescents na, that is 15 years old and above, you usually have them as adults, like adults. But in children, less than 10 years of age, they may have some representations that are not really seen in the adults. Mostly in our cases, we see patients with those with recurrent or chronic upper respiratory infections. In 1 year, ilang beses siyang nagkakaroon noon. Those with oral ulcerations, or early herpes zoster. Yung mga 1 to 2 years of age nagsusoster na. Okay. So these are we have conducted the clinical profile of our patients, HIV patients who presents, and most of the manifestation are oral manifestations, okay, and malnutrition. Okay. So clinical stage 3, there, the unexplained moderate malnutrition, but that is not responding to standard therapy. They have persistent diarrhea, those infections that we cannot explain. They may present with continuous fever, pero ano sila, up and about, okay? And if they have TB, that's why we usually screen our adolescents, especially adolescents with disseminated TB, okay? Or in young infants who have disseminated TB or early in their life. Okay, so for clinical stage 4, those presenting with pneumocystis, Girovechi pneumonia, okay, usually it's a combination of all of these manifestations. We see severe bacterial infections. They are malnourished, severely malnourished. They have extrapulmonary TB and the oral lesions and candidiasis. Okay, so recommendations now for these children and adolescents with HIV. So in all settings, the biological children of a parent living with HIV or those who may have died from HIV, usually nga po, those are the patients die from severe TB, the mother or the father died of TB infection. So yun, tin-test namin yung children, no, for possible transmission for HIV. Okay. So should be routinely offered na the testing. Okay. Rapid diagnostic test. This is a new one that you may be able, kaya nga read na yung ano natin ngayon sa available. Because the virologic test is not readily available in our country, no, in the entire country, especially those hubs, no, who are not hospital based. So in children, okay, the rapid diagnostic test, which is an HIV serology. So you are looking at the antibodies. So as I have said, hindi siya ang perfect test for children less than 18 months of age because of the possible detection of maternal antibodies. So, but in cases that you do not have the NAT or the virologic tests, okay, so it has been accepted that those infants younger than 4 months of age, the HIV exposure status of infants and children 4 to 18 months. So the recommended age is just for 4 to 18 months to ascertain HIV serologic testing in the mother. So it means if you're gonna test a child using the serology test of a 4-month to 18-month-old child, and that test is positive, you should actually have the serologic testing of the mother also. Kasi saan pa manggagaling yon, di ba? So if the mother is also positive and you don't have the virologic test, you can use serology tests, okay, for the child. And if it turns out positive, then you may treat that child. So rapid diagnostic test for HIV serology can be used to diagnose HIV infection among children older than 18 months. So no question about it. So it's already with good evidence. Basta 18 months and above. So the timing, again, the timing should ideally use the virologic testing at birth. Okay. Then the technologies to be used, yun ang gusto natin, RIB the approach, the point of care nucleic acid testing approach. Okay. And then the rapid diagnostic test, serology, can be used now for children 4 months to 18 months of age. For adolescents, it's like how you approach an adult. But here, in settings with a low burden of HIV infection, again, the HIV testing services with linkage to prevention, treatment, and care should be accessible. Okay. So I just would like to approach kanina because you have a question on the indeterminate test results, which we always get from the rapid test, di ba? Lagi na lang may indeterminate na test. So we still have to send to, and even the confirmatory test, may indeterminate din sila. So the recommendation from the WHO is to do further testing. Ayan kung titingnan nyo po, to make sure lang that we have exhausted the determination. But again, you have to, in this case, meron siyang further review by a clinical and laboratory team. Okay, so you also look into the patient, okay, that why did you do the test? Number one, because may clinical symptoms ba siya? Or wala naman, but you want to do it as a screening because high risk siya, di ba? So that may be able, or the timing, no, of the testing. So we have several cases also that the test is indeterminate for twice, uh, two times, and then after the third specimen, then we get the positive test. So at least we did not miss on that. Okay, when to start for children, we start as, or for anyone, for all population, it should be initiated regardless of the clinical stage or the CD4 cell count. Okay, especially for infants diagnosed in the first year of life, because they may have more infections further if you do not start ARTs. So again, rapid initiation is defined as within 7 days from the day of the HIV diagnosis. Okay, and the timing, again, you start. Now, for TB cases, if the child has been diagnosed for TB, but also identified to have HIV, then you start the treatment of TB first, then initiate ARTs 2 weeks after initiating TB treatment. This is a new recommendation because before it's 1 month, even before it's 8 weeks nga po eh. But now it's 2 weeks. And then for those with cryptococcal meningitis, and then the patient was identified to have HIV, then you defer it by 4 to 6 weeks from the initiation of the antifungal treatment. And those with histoplasmosis also, no, the timing is initiated as soon as possible among people with disseminated histo. Okay. So these are the tables that we have included, no, here. Dolutegravir in children. Sa adults, yun na nga po yung meron na ngayon as a combination. And in neonates, no, there's the it cannot be given, dolutegravir cannot be given for less than 4 weeks. So dolutegravir has been tested, okay, because of the high resistance for efavirenz or nevirapine, as high as 69%. So they have identified the favorable pharmacokinetics of dolutegravir. That's why it's now being suggested to be part of the primary, no, or the first line for treatment of HIV in children. Okay, so and the dolutegravir has advantages of having fewer drug reactions and developing drug resistance, and also good activity against HIV-2 infection, which is naturally resistant to your efavirenz. And so the option now is to initiate dolutegravir, no, for the treatment. So monitoring of the treatment is almost the same as how we do it in adults. So the goal is to have viral suppression, okay, and continue the medications for, sabi nga natin, for life. And so my last slide is the cotrimoxazole prophylaxis. So the prophylaxis, no, is initiated for children and adolescents living with HIV, okay, regardless of the clinical stage or CD4 count, but with priority to initiate it in children with HIV if they are 5 years old and below, okay, or if they have advanced HIV disease, or CD4 count less than 350. Okay. Discontinuing it in settings with low prevalence like in the Philippines. Ito pala yung Philippines, yung high prevalence of malaria and severe bacterial infections, it should not be discontinued until adulthood. No? Kasi high prevalence po tayo ng severe bacterial infections. Now, for HIV-exposed infants, we initiate cotrimoxazole prophylaxis starting at 4 to 6 weeks after birth, and then discontinue it once the child has been identified as HIV negative or the HIV infection is excluded. Okay, so it is the future. No, we need more effective counseling and also preparation for women who have tested positive. So what we do in our clinics, in Sagip Clinic in PGH, once the mother has been identified to be HIV positive, we do counseling 1 month before she delivers. So we have coordination with our OB clinics, no, and so that we can do initial counseling to the mother, especially on treatment, adherence, and then the breastfeeding. Okay, so we also want to have better data systems. Okay, not only for the adults but for pediatric patients. So the point of care, early infant diagnosis. Okay, because and even though in our institution we have all these labs available, but point of care is still very helpful, no? And will save us time, no? Okay, so that also helps in integrating this testing to other healthcare services. Okay, so we hope that in the other hubs and in the other hospitals, these testings will be available for children. Okay, so with this, I hope I have answered some of your questions already. And also, you know that the HIV in children, no, is a very complex type of management. So we also have in our clinics the different subspecialties or even services like dentistry, di ba? Kasi in children, sa mga infection, very prone din sila sa mga other infections, lalo na sa mga ngipin nila. Okay, and so and we also engage social health workers, no, so that especially when the pandemic happened, when PGH was identified as COVID referral center, so some patients were we did not close our clinic in Sagip Clinic, but so that we can continue the services. But the problem is some of these patients are afraid to go to PGH to get their drugs or to have a consult because our clinic is away from the OPD, okay, or those who are sick. So what we did was actually, ito best practice na lang po. The social workers were able to call the parents, no, and if they need to the medications, meron pinapag-grab na lang dun sa kanila. So that's part of the service of the clinic, so that we will not miss, no, any of these patients that needs their medications. So I hope that's one best practice. But we need, we need support for that. Okay.